So we made it more categorical even. Yeah.
Thank you. Thank you, Dan. Great presentation and excellent discussion. I just wanted to let you know we're going to move on to the public comment and discussion period now. We had no manufacturers that elected to make public comments today, so we're proceeding directly to our other public commenters. And so we wanted to ask Nathaniel, Kevin, and Andrew to come forward, and we will let them begin their points. Thank you. There's Nathaniel. Welcome to Chicago. We're thrilled to have you here today.
I hold it the whole time.
Whichever your preference.
Oh, that's wonderful. So Nathaniel Counts with Mental Health America, the Associate Vice President of Policy. We're the nation's oldest mental health advocacy organization. And I wanted to make 2 points today. The first one is the same point I make in every written document that apparently people at ICER just immediately know it came from me. And we just submitted this with NAMI, DBSA, and us for the value assessment for 2020. And our point is that we think it's important that when you're modeling the payer perspective on cost, you model public payer perspective different from private payer perspective. Right now, they're assumed to all have exactly the same considerations. But for commercial payers, chances are you might not be their member next year. You're churning around. They only have like sort of limited accountability for your total costs. From a public payer perspective, well, it depends. Like for Medicare 65 and older, I think they often anticipate having you for the rest of your life. And then for children and sometimes young adults in Medicaid, they also expect to have you for quite a while. Even if you churn between Medicaid health plans, CMS itself still has the same perspective. And while you can't do this now, all this wonderful cost modeling that happened, we think it's important that if you do elect to, during the value framework update, take on this kind of modeling to then revisit some of the past ones to see how this would have played out differently. And so the sort of like canonical example is right now, under the societal benefit, you're modeling labor market outcomes and how does it affect productivity. But from CMS's perspective, if you increase productivity by enough, but over a threshold amount, you actually no longer need Medicaid and go into commercial insurance. And then the savings for them isn't just like incremental changes in healthcare utilization. It's actually like they no longer pay for you whatsoever. And so from a normative perspective, that is kind of instantiates the idea that the government has a responsibility to invest in its citizens to develop fully over their life course. And I do not, to the best of my understanding, the CMS Office of the Actuary does not currently do this. They look at changes in healthcare utilization over time in their modeling. I don't think they look at complete disenrollment if you've invested a certain amount. Like I think, and same with the Congressional Budget Office, when they're modeling the Support Act for opioids, I don't think they looked at the chance that you could literally no longer require Medicaid because you've invested enough. Someone has to start setting the precedent and example that investments in behavioral health from a public payer perspective pay off in life course human development. And I think ICER is positioned to take the lead. And even though there's not a lot of data for a lot of this, even beginning to at least do like kind of loose scenario analyses, I think would begin to kick the can down the road a little bit. So I think that was the first point I wanted to make. And then the second one is the relationship between the ketamine and esketamine and access. One of the issues we face is that to the extent ketamine isn't well covered by Medicaid, a lot of people functionally won't have access to it, pretty much independent. I mean, and any cost in the hundreds per dose is going to be inaccessible for a lot of people. So that can make it a false comparator. So I just wanted to kind of put that on the table as access as being, I think, a relevant consideration when you're thinking about comparing multiple therapies for treatment-resistant depression, especially given that Medicaid and Medicare, CMS generally are the largest payer of behavioral health services. And thank you so much.
Yeah. Hey, can we just have a quick reaction to that? So, Nate, thank you. Actually, you beat me to it because I was going to throw that in as a potential other benefit that at least should be acknowledged as potential, that for public payers, investment, I like that term, in their health may actually prove a financial benefit if they're no longer on their books. We may want to work with you, too, just to make sure that if we incorporate anything like that approach, we don't send the opposite signal to the private payer community, which is if you can figure out how to scrimp in just the right way, they'll end up in Medicaid and they're off your books. Yeah. So we want to be careful that what we send is an overall message that we all care about patients as human beings, not as enrollees in one insurance form or another. And I understand your policy perspective, which is we have to have decision makers understand that there may be a reason to invest significantly in health for multiple reasons. So I think we'll look forward to working with you to figure out how to do this right.
Thank you. Kevin.
Hi, I'm Kevin Einbinder. I'm the Vice President of Programs and Communications at the Depression and Bipolar Support Alliance. I have a prepared statement I wanted to read to you. As a nationally recognized, can you hear me okay? Okay. As a nationally recognized and balanced voice for people with the lived experience of mood disorders, the Depression and Bipolar Support Alliance respectfully share these comments to the Esketamine for TRD Effectiveness and Value Evidence Report. DBSA recognizes that the aim of this project is to evaluate the health and economic outcomes of esketamine for TRD. However, treatment options, priorities for patients are often not in alignment with the priorities of clinicians and health economists. When assessing the clinical and economic value of esketamine for TRD, we ask ICER to give equal weight to the broader impacts of TRD, look beyond the clinical and economic value of clinician-defined outcomes, and consider the entire needs of the person. In 2018, DBSA created and distributed the Supporting Wellness Survey. The survey was used to learn how people living with mood disorders prioritize treatment options. The survey was launched in August of 2018. We had over 6,000 responses, making it one of the largest surveys of its type. Insights from this survey will be provided to support our belief that meaningful assessment of clinical and economic value of esketamine will be aided by understanding how those receiving treatment define success rather than simply relying upon a list of symptoms observed by clinicians with tools created by researchers several layers removed from the patient community. That every person deserves the opportunity not just to survive, but to thrive, and that the whole health ramifications that lead to a patient-driven risk-benefit analysis rather than a clinician-observed tool-based benefit. While symptom relief and side effect management are captured by clinical trials, a data gap remains in measuring well-being. 90% of respondents to the Supporting Wellness Survey stated that they strongly agreed or agreed that their health goal is to function as well as possible, especially in how they function at work, play, and with others. This stands in stark contrast to a clinician-observed improvement in symptoms and demonstrates why limiting information to clinical effectiveness, such as the Montgomery-Åsberg Depression Scale, is inadequate. Several scales, such as the Rife Scale of Psychological Well-Being, the Sheehan Disability Scale, and a WHO-5 Wellbeing Index measure well-being domains. The focus of these scales is improvement in environmental autonomy from an interpersonal relationship and work-school perspective. Because these scales do not focus on the reduction of a given symptom, their use of global questions more accurately reflects an individual's unique experience living with TRD and whether the treatment is bringing improvement to their lives. Most recently, 2 posters were presented at the 2018 Psych Congress, demonstrating how patient-centered outcomes can be matched to traditional symptom-based scales, including one that documents the use of a goal attainment scale in a clinical trial. In the closing comments made at the November 16, 2018 DBSA externally led patient-focused drug development meeting, Dr. Michelle Campbell from the Food and Drug Administration stated she understands the request from the community to add thriving to FDA description of clinical benefits and the agency's guidance to industry. During that same meeting, participants were asked to provide further context to domains of wellness that move beyond functioning to thriving. In discussions around this priority, panelists and audience participants shared that underemployment was a significant barrier to achieving a thriving life. Underemployment intersects with the ICER-identified concern that patients with TRD have higher costs of care, decreased work productivity, and account for $64 billion in total costs. When evaluating economic value, it only makes sense that ICER would include quantitative and qualitative tools that include peer-defined priority wellness domains, as positive movement along these domains have potential to significantly reduce the total cost of the U.S. healthcare system and the economy. In the Supporting Wellness Survey, 43% of the individuals shared that their overall health was generally worse since experiencing symptoms, and 37% that the stability of their health is worse. Why is this? While more research is needed, the evidence document points to some answers. Treatment is often initiated by a primary care physician. Initial treatment may not work. Switching to a different therapy is common, and patients may find it difficult to remain on therapy long enough for an adequate trial, especially if there are side effects. Treating TRD is as complex as the number of pharmaceutical interventions currently available. Given the wide variety of medications, the different side effects associated with them, and the fact that symptom relief is not the greatest benefit a person living with TRD is seeking, it is not surprising that people don't often take the medication as prescribed. A central theme heard at the DBSA patient-focused drug development meeting was a necessity to weigh the benefits of taking a medication while debilitating side effects against the risk of leaving their mental health condition untreated. People are not compliant when they choose to treat one health condition as a priority over another. They are weighing the clinical and economic value of the treatment options available to them to treat their whole health. The idea of wellness cannot be embraced without considering the whole health of the individual. An untreated or undertreated TRD can disproportionately negatively affect an individual's whole health. Therefore, assessing the clinical and economic effectiveness of esketamine cannot be untangled from the effects on the whole health of the person. Finally, 89% of respondents to the Supporting Wellness Survey shared that there should be better ways to treat and provide care. New treatments for TRD are welcome and needed. The lack of objective and quantifiable measurement tools in a clinical trial model necessitates additional acceptable measures to get a complete picture of a medicine's potential risks and benefits, including well-being. Patients' reported outcomes have potential to move beyond the clinical trial model to capture what is truly important to patients.
Hey, Kevin.
Yep.
Are you at the end? Are you about at the end of your?
About 2 more sentences. Okay. This model takes into consideration the lost opportunity costs when effective medication to treat TRD are not available and would enhance ICER's leadership position in understanding the cost effectiveness of healthcare intervention. Thank you.
Thank you. Andrew. If you hold it whole time.
Oh, well, I'm not going to do that. Good afternoon. I'm Andrew Sperling. I'm the Director of Legislative Advocacy for NAMI, the National Alliance on Mental Illness. NAMI is the nation's largest national organization representing and advocating on behalf of people living with serious mental illness and their families. We have over 600 state and local organizations providing support to people living with mental illness and their families. We also engage in policy advocacy as well. This has been covered, the massive burden associated with treatment-resistant depression, $64 billion. The mortality related from suicide, which now exceeds, in the United States, mortality from breast cancer and prostate cancer combined. Why? Because we've had effective interventions with breast cancer, or early intervention, better treatments for breast cancer and prostate cancer, and it's been on a glide path down. Suicide staying at about 40,000 a year. 90% of the suicides in this country involve poorly treated mental illness. So this is a public health, an enormous public health problem. I want to remind everyone that this was designated by the sponsor and by the FDA as a breakthrough therapy. This is not a Me Too product. This is a breakthrough. This is something we've been waiting for a very, very long time for people who struggle with treatment-refractory depression for years and years and years, and now they finally have hope and an answer. What makes it different, one of the things that makes it different is the separation it provides for patients fairly immediately. Your typical antidepressant, your SSRI, your SNRI, requires sometimes 4 to 6, sometimes even 8 weeks to show clinical benefit. The people in the clinical trial with esketamine, we're showing symptom relief within hours. That's enormous. To take a medication for 6 to 7 weeks, and your clinician having to tell you you're not getting any better, but just stay with it, despite what can be, not just uncomfortable, but really debilitating side effects. To be able to get symptom relief this quick is a huge, huge breakthrough. So one of the points I want to bring up first, and these were in NAMI's written comments that were submitted for the record in this process, is how esketamine is different from ketamine. And what I mean by that is right now, Dr. Is it Kersey? Is going to tell us more about how she operates a ketamine clinic with psychiatrists overseeing it and mental health professionals working with people that go to that clinic. I want to note for the record, in many parts of the country, that type of state-of-the-art ketamine clinic does not exist. And in many cases, to get ketamine, patients have been going to ketamine clinics, which are by and large run by anesthesiologists, very talented, bright people, but their experience in treating people with treatment-resistant depression is limited. So when you talk about using it as a comparator, recognize that this is likely in many cases not a psychiatrist that's writing a prescription, and they are doing this on their own, compounding this, mixing up the ketamine and doing it IV to a patient. This is not someone taking a drug, administering a drug or prescribing a drug for an on-label purpose for which there are randomized controlled trials, multiple randomized controlled trials that demonstrate both safety and efficacy. I would also observe that many of these ketamine clinics are either not paid for by private insurance or not paid by Medicare and Medicaid. So when we talk about the economic impact, what matters for a patient is what they're actually going to pay to get that. So if they have a good benefit, say under Medicare Part D, or they're, even more importantly, what's called the LIS or low-income subsidy, they're going to be able to access that esketamine through their Medicare Part D plan, in some cases by only paying $3 or $4 or $5 for the prescription if they qualify as a dual eligible or the low-income subsidy. So what's going to matter to that patient on an economic basis is what it's going to cost them to access the therapy, and that's not always the case with a ketamine clinic that's not covered by insurance and not covered by Medicare. NAMI wants to go on record again. Also the REMS. It's important to note that we have a REMS here in terms of protecting safety. That REMS does not exist for off-label prescribing of ketamine. Those of you that reviewed it, I think it's in the review, but if you don't know, the sponsor is required to follow this REMS. They have to limit distribution to certified clinics where they've trained prescribers, where they're enrolling patients in a registry, and there's required monitoring of patients for a minimum of 2 hours after administration. That does not exist when someone goes to a ketamine clinic to get treatment with ketamine for IV ketamine for treatment-resistant depression. Limitation on qualities. NAMI has made this argument again and again on the use of qualities. Many of our interventions for serious mental illness are not extending life expectancy. And that immediately creates a limitation in qualities capturing what matters to people living with serious mental illness. And in fact, we have a lower life expectancy than the rest of the country, at least for people with serious mental illness. They actually, on average, have a lower life expectancy of 25 years. Why is that? Well, I think we talked around this in the presentations earlier. The fact of the matter is these individuals have dramatically higher rates of diabetes, heart disease. So when you experience treatment-resistant depression, your ability to engage in a healthy lifestyle and healthy eating with dramatically higher rates of tobacco consumption. So when you're in the grips of a depressive episode, your ability to quit smoking, to exercise, to engage in a healthy diet, all those different things, you end up with a sedentary lifestyle, and then we're suddenly stunned 20 years from now when there's dramatically higher rates of heart disease, diabetes, COPD, and other things. So recognize these are already individuals with a lower life expectancy because of the poorly managed chronic diseases that they're dealing with, and they can't, quite frankly, effectively manage because they're dealing with depression.
I really appreciate your.
No, I'm sorry.
No,
I'm done. That was it.
I appreciate your comments in terms of the integration of medical and behavioral health, and I think it's we definitely do not want to overlook that. It's an area of work of mine, and I appreciate you raising that. Kevin, Nathaniel, and Andrew, thank you for your comments. Do we have any responses from the ICER staff or ICER team? Great. Any thoughts or comments from the Midwest CPAC? So we're going to move into the voting. Oh, Don? Go ahead.
Just that I think this is right. For the population we're dealing with today, we're not talking about patients with TRD who have other serious medical conditions. Do I have that right?
Sure.
Yeah, okay.
Tim, yeah.
Okay, real quick question. I appreciate you bringing up the question about employment and labor and all that, those costs for Medicaid and all this. But I think my question is going to be for Dan. You accounted for labor, employment-related costs. Do you have a reaction to what they said about this? Because those costs were in your models, but do you feel they're adequately compensated for? And then on the Medicaid side, I would assume that the medical costs are somewhat modeled by this as well.
Yeah. So the medical costs were modeled. There's limitations, again, that I mentioned some of the limitations with the data that's available. But when it comes to, and I'll just have you repeat the first part of your question. Which
I was interested in their comment about
employment.
the fact that this would have a positive impact on their employment, both in the short run and the long run. And, that would have a spillover effect. I would guess you didn't model the tax effect and that sort of secondary effect, but it looked to me like you modeled the effect on their actual individual wages.
Yes. We did model labor costs. Again, there's limitations in the study that was used there. It only looked at those patients. There's a proportion of patients who are working in this population. And the study that we utilized only looked at those patients who were working and their ability to work more or return to work once their depression symptoms resolved. So again, there's a lot more work that needs to be done. Unintended pun. But there's more that needs to be done to better understand whether patients can go back to work with use of these therapies. There's no data on the impact of therapies on productivity or ability to go back to work. There's very, very limited data.
Errol.
And
I just wanted to ask about this question about co-occurring substance use of various sorts. Obviously, a lot of patients with TRD are self-medicating or are just trying to, all kinds of personal strategies. And is there something that either makes this more or less attractive in terms of dealing with those kinds of issues that people face when we think about the characteristics of both ketamine and this medication, how it might relate to sort of those dual diagnosis issues or substance use issues?
Well, I would just observe that and someone who's going to actually be prescribed esketamine, they're already engaging in help-seeking behavior, as opposed to many people who have depression with comorbid opioid abuse or alcohol abuse. They're not actively seeking treatment, by and large. And that's, to me, is the difference. This is someone actually going to actually get a prescription for their depression. And it's when you talk about self-medication, that's, to me, is the issue. People who are with depression who are actively abusing substances are much dramatically less likely to be actually going to seek professional help.
People using ketamine in the street market for the same purposes?
I don't actually have an answer for that. I would imagine it's fairly high. If they're already abusing other street drugs or abusing alcohol, they may be engaged trying to seek out ketamine as a street drug. I don't think that's going to be an issue with esketamine relative to, at least I was actually at the FDA advisory committee meeting. I think Nathaniel and I were there. What was made clear was the way this is being packaged, there's virtually no way it can be diverted for street use.
Think of it as a harm reduction approach.
Yeah, potentially, yeah.
There actually are, you can find on the internet people describing how to take ketamine that you bought at a rave or something and make tiny micro doses of it and use it to treat yourself for depression. So that does exist.
Thank you. I think we need to move into the voting phase. Steve, I'm sorry, we're a little behind schedule, but I think we've got some time.
We do. All right, let me grab, thank you very much to our public commenters.